Hello friends, welcome back, and today we are with our topic local anesthesia part 2. In this part we will discuss about pharmacodynamic of local anesthesia, factors affecting local anesthetic actions, classification of local anesthetic agents, and pharmacokinetic of local anesthesia. First of all, pharmacodynamic of local anesthesia, which depend on onset of action of local anesthesia, duration of anesthesia, and recovery from the local anesthesia. So what is onset of action? Onset of action is induction time, means is defined as a period of deposition of LA or deposition of anesthetic solution to complete blockade, nerve blockade. And this nerve blockade or this onset of action is affected by diffusion of local anesthesia into nerve. So this rate of diffusion of local anesthesia into the nerve is governed by some feature. That is, number one is structure feature of the nerve, then concentration gradient, and then core fiber or mantle fibers. So first of all, structure feature. As you all know that a peripheral nerve is composed of 100 to 1000 of tightly packed axons. These axons are protected, supported, and nourished by several layers of fibrous and elastic tissue. Nutrient blood vessels and lymphatics course throughout the layers. Individual nerve fibers are covered with and separated from each other by endoneurium. So each fiber has its covering, which is the endoneurium, and the perineurium then binds these nerve fibers together into the bundle called fasciculi. So each fasciculi contains at least 500 to 1000 nerve fibers. So each nerve fibers has covering endoneurium. Then they 500 to 1000 nerve fibers group together to form a bundle whose covering is perineural sheath. So this perineural sheath separates one fasciculi from the other fasciculi. And innermost layer of this perineural sheath is known as the perilemma. And importance of this perilemma sheath is it is a main barrier to the entry of LA into the nerve fibers. So main barrier to diffusion of LA is perilemma, which is the innermost layer of perineurium. And what is the perineurium? It's the covering of fasciculi. And what is fasciculi? This is a bundle containing at least 500 to 1000 nerve fibers, and each nerve fibers has its covering, that is endoneurium. Then these fasciculi contain into connective tissue, which has the blood vessels, and this connective tissue is known as the epineurium. And the outermost layer of this epineurium condensed or dense thick layer, which is known as the epineurial sheath. This epineurial sheath is not a barrier to diffusion. So barrier to diffusion is perilemma. So for example, we have inferior alveolar nerve. Inferior alveolar nerve at the level of lingua contains 18.3 fascicles. So endoepineurium, which is a connective tissue, constitute 30 to 75% of total cross-section of the nerve. Concentration gradient. So in concentration gradient, when LA is injected into soft tissue, three-dimensional diffusion of local anesthesia occurs. That means it's not diffusion not only in the nerve tissue but also to nearby blood vessels and interstitial fluid take place. So this diffusion occurs according to the concentration gradient. Concentration gradients means from high concentration to low concentration. When LA is injected into the soft tissue, then nerve has no LA inside it and soft tissue has the LA. So concentration gradient occur So movement of or diffusion of LA take place from high concentration to low concentration. That means from soft tissue to the nerve tissue. But it's occurred according to the concentration gradient, according to its mechanism. That means the unionized form of the LA solution goes inside the nerve. Then ionized form of LA is attached, bind to the receptor site and is take its action. So, but this diffusion not only occur in the nerve tissue, but diffusion also occur in the blood vessels or interstitial tissues. Then there are cord fibers and mental fibers. So when LA is injected, mental bundles are the first one reached by local anesthetics and are exposed to high concentration of it. The fasciculi are located in near the surface of the nerve. They are the mental fibers. And due to this, mental bundles are usually blocked completely shortly after injection of local anesthesia. And fasciculi form closer to the center of the nerve. They are known as the core bundles, and they contacted with by the local anesthesia only after much delay and low concentration. Because of greater distance, their solution must traverse and great number of barriers to be crossed. So core fibers are exposed to decreased concentration of local anesthesia, which explain a clinical situation of inadequate pulpal anesthesia developing in the presence of subjective symptoms of adequate soft tissue anesthesia. Complete conduction blockade occurred with the adequate volume and adequate concentration. So if we have adequate volume, adequate concentration, then complete conduction blockade occur. And second, this depend on fibers, mental fibers and core fibers. Mental fibers, as I have told earlier, near the surface of the nerve, and core fibers in the inside of the nerve. Or mental fibers, like in case of inferior alveolar nerve, you can take the molar areas are supplied by the mental fibers. And in the case of core fibers, incisor and canines, incisor and canines in case of inferior alveolar block are core fibers, supplied by core fibers. So complete conduction blockade depends on these fibers also. Mental fibers blocked first, core fibers, then later after the mental fibers. Recovery from the LA emerges from LA nerve block follows same diffusion pattern as the induction, but in reverse order. Means when extraneural concentration of local anesthesia is continuously depleted by diffusion, dispersion, and vascular uptake of the drug, while the intraneural concentration of local anesthesia remain relatively stable. So once the concentration gradient reverses with the intraneural concentration exceed the extraneural concentration, the anesthetic molecule begins to diffuse out of the nerve. The fasciculi in mental lesion begin to lose the local anesthesia much sooner than core bundle. So early in the core bundle, first diffuse into the mental fibers, and then from the mental fibers, it diffuse extraneural site. So core fibers lose the LA action first. So mental fibers remain anesthetized for longest and core fibers anesthetized for shortest. Take the example of the inferior alveolar nerve block. According to concentration gradient, LA diffuse into the nerve. Mental fibers block first, which block the innervation of proximal region. Example, molars and soft tissue anesthesia occur. Then LA reaches the core toward the core fibers and block the distal regions like incisors and pulp anesthesia occur. Now, concentration gradient again develop. Here now LA more inside than outside. That is more intraneural than extraneural side. So diffusion in reverse direction start due to which LA action wears off. So first LA diffuse from mental fibers to outside. Now concentration gradient occur between mental fiber and core fiber. So LA diffuse from core fiber to mental fibers. So LA effect from core fibers bear off first, which means pulpal anesthesia or incisor or canine anesthesia bears off before the molars. Duration of local anesthesia means time from the onset of action to its action bear off. That means its duration of anesthesia is a time from onset of action, that is when the LA action started, to when the LA action wears off or its action stopped. This is a duration. The onset of nerve block is always rapid and recovery from the nerve block is slow. Why slow? Because LA is bound to nerve membrane. And recovery also depends on the vascularity of the injection site. If vascularity is low, the duration of LA action prolonged. And also it depends on the presence or absence of vasoactive substance. So if vasoactive substances are present, then they will prolong the duration of the action of the LA by vasoconstriction. Factor affecting the local anesthetic action. There are various factors which affect the local anesthetic action. First of all, pKa value, that is the dissociation constant. And this pKa affects the onset of action of local anesthesia. Low pKa means results in more rapid onset of action, as more unionized molecules are present to diffuse through the nerve sheath. Second, lipid solubility. The lipid solubility affects the anesthetic potency. So, increased lipid solubility result in increased potency. So, etedo can produce conduction blockade at a very low concentration and can fully suppress nerve conduction even at higher concentration, because etidocaine is 140 times more potent. Then protein binding. Protein binding affects the duration of action of LA. Increased protein binding allows anesthetic cations to be more firmly attached to protein located at the receptor site. As we all know that cationic form is necessary for attachment to the receptor at the specific receptor of the nerve sheath inside the nerve. So we know unionized form needed for diffusion, but ionized form needed for binding. So if protein binding is more, then there is more duration of action. Then non-nervous tissue diffusibility, it affects the onset. Increased diffusibility in the non-nervous tissue means interstitial tissue or blood vessels, that result in decreased time of onset. Vasodilator activity affects the anesthetic potency and duration. If there is greater vasodilator activity of the local anesthetic, means increased blood flow to that region, means more removal of the local anesthesia away from the injection site. So anesthetic potency and duration both decrease as there is no LA, because all the LA will diffuse into the blood vessels. Then where will the LA to take place for onset of an action? So the vasodilator activity or non-nervous tissue diffusibility, these two factors are decrease the LA action, and protein binding, lipid solubility, and dissociation constants. These increase the LA action. Then comes to the classification of local anesthesia. So local anesthesia classified according to various rules. Number one is based on duration of action. We have ultra short acting anesthetics which have the action less than 30 minutes. Then Short-acting anesthetics, which have duration of action 45 to 75 minutes. Medium-active anesthetics, 90 to 150 minutes. And long-acting anesthetics, which have duration of action more than 180 minutes or longer. Then it is classified according to surface anesthetics, are soluble or insoluble. Soluble agents are mainly cocaine, lidocaine, or tetracaine. Insoluble agents are benzocaine or oxytazine. Then is classified based on the biological site. So class A, agents at the receptor site on the external surface of the nerve membrane, example biotoxin. Class B, agent acting at the receptor sites on the internal surface of the nerve membrane, that is our lidocaine. Agents acting by the receptor dependent physiochemical agents are class C, example benzocaine. And agents acting by combination of receptor and receptor independent mechanism, that is articaine or prilocaine, are class D, a local anesthetic agent. Local anesthetics are also classified by their ability to react with specific receptor sites in sodium channel. So these are number one within the sodium channel, that is tertiary mean or local anesthetic. Tertiary mean local anesthetics like lidocaine, articaine, mepivacaine, prilocaine or bupivacaine. At the outer surface of sodium channel, that is tetrodotoxin, hexadoxine. At the activation gate or inactivation gate, scorpion, binom. Now comes to our main classification, which is based on the chemistry, that we have the three types of LA based on their linkage. Ester linkage are the esters LA, amine linkage are the amines and quinones. In ester type LA, we have two types of LA, benzoic or para-aminobenzoic. In benzoic, we have examples butadiene, cocaine, benzocaine, tetracaine, and pipercaine. In para-aminobenzoic acid, procaine, chloropropane, or fucoxycaine. In amide type of LA, we have articaine, lidocaine, bupivacaine, mepivacaine, or prilocaine. And in quinolone, we have cent-bupiridine LA. Now we have pharmacokinetics of local anesthetics, which, as we know, any drug's effectiveness increases when it is absorbed in circulatory system, which is reverse in case of local anesthesia. So its effectiveness decreases if it is absorbed in the circulation. So pharmacokinetic of local anesthetics. What do you mean by pharmacokinetic word? It means how a drug moves inside the body. Pharmacodynamic, what a body does to drug, and pharmacokinetic, what a drug does to the body. So pharmacokinetic of local anesthetics depends on various factors like its uptake, its distribution, its metabolism, and its excretion from the body. So when LA is taken by three routes, mainly oral route, topical route, or IV route. With the exception of cocaine, LA are absorbed poorly from GIT tract after the oral administration. So whenever LA is orally taken, it first go into the GIT, hepatic bypass, first pass effect occur, and it by transformed into inactive metabolites, which hinder the oral use of lidocaine as anti-dysrhythmic drug. And when we taken it as a topical route, in topical route there are different rate of absorption applied to the applied to the various mucous membrane according to mucous membranes. Like tracheal mucosa have very good rate of absorption. Then it comes the pharyngeal mucosa, and esophageal or bladder mucosa has least poor, or you can say poor rate of absorption. And in IV, it's a 100% viability. The benefit to be accrued from IV drug administration must always be carefully weighed against any risk associated with the IV administration. But we are here discussing local anesthetic effect in oral cavity to anesthetize the soft tissue. We are not discussing the local anesthetic effect as a antidysrhythmic agent. So in case if we want local anesthesia, so we want to block the nerve conduction. So in that case, if we take an LA orally, it does not affect. If we take LA local anesthetic agents IV, does not affect. Nerve blockade don't occur. And if we apply topically, then nerve blockade occurs some effect occurs somewhat according to mucous membranes. But if we inject the LA in the soft tissue in the proximity of the nerve, where there is nerve present, then it enters the nerve sheath or nerve tissue according to its mechanism of LA, according to its diffusion, according to concentration gradient, it will enter the nerve tissue and nerve blockade will occur. So antirhythmic effects, which is very good if taken as a IV, but if we want nerve blockade, we want to do the painless surgery, then we have to give the nerve block in the vicinity of the nerves. Then nerves, nerve taken whether it's LA taken whether it's topical, oral, or IV route, they produce vasodilation. Except the cocaine. Cocaine is the only anesthetic agents which produce vasoconstriction. So cocaine is a potent vasodilator. So we have one advantage of cocaine. Sometime intra-arterial vasoconstriction occur due to the emergency or accidental due to the accidental insertion or injection of thiopental sodium. So that cause a vasoconstriction. In that case, procaine is very good as it is the potent vasodilator. So its vasodilating effect in duration and quality, control the duration and quality of pain. Then come to the distribution. After uptake, LA is distributed throughout the body from the blood. As when we take after uptake of the LA, it absorbed into the blood, and from the blood it distributes throughout the body to all the tissues. Then is that diffusion into the body parts depend on the perfusion level and muscle mass. So highly perfused organs like brain, head, kidney, liver, lung, spleen will have high anesthetic blood levels than less perfused organs. And skeletal muscle contain greater percentage of the local anesthesia because of large mass of the tissue in the body. The blood level of local anesthetic is influenced by the rate at which drug is absorbed into the cardiovascular system. Second, rate of distribution of the drug from vascular compartment to the tissues. Now, number 3, elimination of drugs through the metabolite or excretory pathway. Then elimination of drug depends on the elimination half-life. What is elimination half-life? It is a rate at which a local anesthetic is removed from the blood. So it is the time necessary for 50% reduction of the drug in the blood level. So we can take a 100% drug. So in first half-life, 50% of drug will eliminate it from the body. Then 50% left. In second half-life, 50% of this 50% will eliminate. Then we have 25% left. Then in third half-life, 50% of this 25% will eliminate in third half-life, which remains 12.5%. And then 50 by reducing 50%, 50% in approximately in sixth half-life, we will left with the 1.5% of drug in the body tissue. That means we have eliminated 98.3% of the drug from the out from the body. So this is elimination half-life. So 6 half-lives are equal to 98.5% reduction of the drug. Then metabolism. So metabolism of biotransformation is depend on the type of the local anesthesia. If faster type of anesthesia, then they hydrolyze in the plasma by the enzyme pseudokinase. So person having the deficiency of this enzyme will be relative contraindicated for the local anesthetic administration. And second, amide type of LA have the little bit complex biotransformation as it will take place in the liver. Prilocaine has biotransformation in liver as well as in lungs. The rate of hydrolysis has impact on the potential toxicity of local anesthesia. Chloroprocaine rapidly hydrolyzed, so it is least toxic. And tetracaine hydrolyzed 16 times slower than chloroprocaine, and it is more toxic. Procaine has the hydrolyzed into para-aminobenzoic acid and diethyl alcohol. Para-aminobenzoic acid excreted unchanged in the urine, and diethyl alcohol further biotransformed into the smaller agents. So toxicity is not due to the parent compound, it is due to its metabolites which occur, they are harmful. Like you can say, take the example of the prilocaine. So in case of prilocaine, the toxicity not due to the prilocaine but due to the orthotolidine, which is its products and which cause methemoglobin, which form the methemoglobin, which cause the methemoglobinemia. So methemoglobinemia is caused due to this. So which is the prilocaine does not cause the harmful effect, but its metabolites cause the harmful effect, as we have seen. So the kidneys are the primary excretory organ for both the local anesthetics and its metabolites. A proportion of a given dose of local anesthetic is excreted unchanged in the urine, and this proportion varies according to the drugs. Ester type LA appear only in very small concentration as a parent compound in the urine because they are hydrolyzed almost completely in plasma by cholinesterase. And procaine appears in the urine as PAVA 90% with 2% unchanged. Amide are usually present in urine as a parent compound in a great percentage than the esters, primarily because of their more complex process of biotransformation. Patients with significant renal impairment may be unable to eliminate the parent local anesthesia compound or its major metabolites from the blood, result in slightly elevated blood levels, so increased potential for the toxicity. So, summary of today's topic is that we have discussed first of all about the pharmacodynamics of the LA, in which we have discussed about its onset of action and duration of action. In onset of action, we have discussed a little bit about nerve structure, in which we have told that perilemma is the main barrier to the diffusion of the LA. And if a diffusion is occur properly, then onset of action start rapidly. So onset also is rapid process. So perilemma is the main barrier. Then we have discussed about the fibers, mental fibers and core fibers, in which we discussed the mental fibers anesthetize first, but the effect of anesthesia bear off last in mental fibers. So core fibers which anesthetize in the last, but action of anesthesia bear off first. So core fiber. So sometimes we see in our clinical life or clinically that patients sometimes feels pain. And if we ask about the subjective symptoms of local anesthesia, they will say they have the subjective symptoms, but still they're feeling the pain. So the core fibers may be the reason for their pain. And next, sometime the patient during the procedure, we are doing the procedure, and in between the procedure, patient telling about the pains, and instead they have soft tissue anesthesia, but they start feeling the pain, and that is due to that core fibers bears anesthesia effect bears off is rapidly from the core fibers. Anesthesia, local anesthesia effects, it depends on the concentration and volume of the LA injection we are giving. So it's depend on this. So we have to give the proper injection of LA. So then we have discussed about the pharmacokinetic of the local anesthesia, in which we have discussed about the uptake of anesthesia. If we are discussing about nerve blockade, in that case we have to give the local injection in the vicinity of the nerve. But if we are discussing the antidysrhythmic action of the local anesthesia, then IV route has the 100% viability. But we should outweigh the risk also. Risk benefit ratio, we have to take that into the consideration. Then we discuss about the after uptake, we discuss about the distribution. When LA is injected into blood, if we are taking antidysrhythmic action or other actions instead of the nerve block, then if LA is injected into blood, it will distribute it throughout the body. And we all know that one thing, that all the drugs when given in the IV route into the blood, their action will increase 100% due to 100% viability. But in case of LA, if we are talking about the nerve block or pain block, then if it is go inside the blood vessel, its action decrease. So this is distributing, and when it is distributed through the blood vessels in the tissue having the high blood perfusion will take the more local anesthetic agents, and as well as tissue having the more mass like skeletal muscle, that also contain the high percentage of local anesthesia. Then we have discussed, after distribution, we discussed the metabolism. Metabolism of this occur in the if Astra type LA, then it occur by the in the plasma cholesterol, and if amide type, then it occur in the liver. So amide type have little complex type of hydrolysis, like the protein, they have lung as well as liver, both. Its hydrolysis occur in both. Then we have discussed the elimination half-life, in which half of the drug will eliminated in first hour, and we have 6 half-lives, in which 98.3% drugs out from the exit through the body. So then we have discussed about the excretion. In excretion, mostly kidney excrete the drugs in the urine, but ester type LA as local anesthetic agents are completely hydrolyzed in the plasma, so they very little loss in the urine. And then we have discussed the various classifications. So we have various types, in which we have main important classification is according to chemistry. And according to chemistry, we have ester type LA, amide type LA, or quinonols.